Chapter 7 will cover common injuries to the upper extremity. If the lower extremity, namely the hip, requires great strength and stability so that we may stand upright, the upper extremity is just the opposite. We sacrifice stability in the interest of mobility. Clearly, our increased mobility allows us to perform many activities, but sometimes the lack of stability is problematic. Injuries to the upper extremity account for approximately 23% of the injuries seen in the sports medicine environment. That rate may be much higher for specific sports. The repetitive demands of overhead sports can create unique chronic injuries for the shoulder and the elbow. Another downside of our upright posture is our natural tendency to fall on an outstretched hand, or foosh, to break our fall, which can create a number of injury scenarios for the upper extremity, particularly at the elbow, forearm, wrist, and hand. The shoulder is a hypermobile joint that allows the upper extremity to assume a wide range of positions. As in most cases, this mobility comes at the expense of shoulder stability. The increased mobility places the articulations and associated soft tissue structures at a greater risk for both acute or chronic injury. The motions of the shoulder include flexion, extension, abduction, adduction, circumduction, internal and external rotation, and horizontal ab and adduction. The shoulder girdle is comprised of 4 bones: the sternum, clavicle, scapula, and humerus. This girdle attaches the upper extremity to the axial skeleton. 4 articulations reside at the shoulder girdle: the sternoclavicular joint, the acromioclavicular joint, the glenohumeral joint, and the scapulothoracic articulation. Abbreviations of these joints are provided on the slide. The SC, AC, and GH joints are true bony articulations, while the ST articulation allows the scapula to glide on the ribcage. All of these articulations must work together to allow for a fully functional shoulder girdle. The scapula must be able to move and adjust its position to allow the humerus to be properly positioned for optimal function. Dysfunction of the scapula is often a contributor to chronic issues at the shoulder, thus making scapular control exercises a staple of upper extremity rehabilitation programs. 3 bones make up the elbow: the distal humerus, proximal radius, and the proximal ulna. The movements that take place at the elbow are flexion and extension. 3 distinct articulations make up the elbow joint: the humero-ulnar, the humeroradial, and the radio-ulnar. The proximal ulna has a significant bony prominence called the olecranon process, which is a pointy portion of the elbow and a common site for contusions and abrasions. The elbow is supported on each side by the ulnar and radial collateral ligaments. The bony configuration of the elbow adds to its stability in the varus and valgus directions. These elements combine to make the elbow a fairly stable joint. Injuries to the wrist and hand run the spectrum of minor to potentially debilitating. 2 rows of carpal bones are present in the wrist. The proximal row articulates with the radius and ulna, and the distal row articulates with the metacarpals. The proximal row of bones from lateral to medial are the scaphoid, lunate, triquetrial, and pisiform. The distal row of bones from lateral to medial are the trapezium, trapezoid, capitate, and hamate. In addition to the 8 carpal bones, there are 5 metacarpals and 14 phalanges. The clavicle is commonly fractured in active participants, with the most common mechanism of injury being from a direct blow, indirect forces from a fall on the point of the shoulder, or a foosh mechanism. It is typically fractured at the distal third of the bone, as this is where it changes shape. The clavicle fracture is treated with a period of immobilization with some allowable motion of the glenohumeral joint for a period of 4 to 8 weeks. This will also depend on the severity and location of the fracture and the desired activity of the patient. If severe enough, surgical intervention may be necessary. The scapula and humerus are also possible locations for fracture in the shoulder region, but are less common than clavicle fractures. The common mechanism of a humeral fracture is foosh, with the mechanism of a scapular fracture being a direct blow. Both will require immobilization of the shoulder and arm for further evaluation and radiographs. Common sprains of the shoulder girdle include injuries to the SC, AC, and GH joints. A sprain to the SC joint results from an indirect force transmitted along the clavicle to the ligaments that support the articulation between the sternum and the proximal clavicle. A sprain to the SC joint is less common than those to the AC joint. However, they can occur in sports where forces are applied to the point of the shoulder. SC joint sprains are tender to palpation and may present with deformity at the proximal clavicle. If the clavicle is displaced backwardly or posteriorly, It can interfere with the subclavian artery and vein and create a life-threatening situation. Most stable sprains will heal well with a period of rest and immobilization. Unstable SC sprains may require surgical repair. The AC joint sprain is often referred to by laypersons as a separation of the shoulder. The degree of injury and resulting deformity of the AC joint correlates with which ligaments have been injured and the amount of damage to each. Patients who have sustained an AC sprain will often have an observable deformity on top of the shoulder due to swelling or the distal clavicle riding higher than normal. An AC joint sprain will be painful and pain will increase with movement. AC sprains have their own classification of severity. The Rockwood AC joint classification has 6 types, with 1 being the least severe and 6 being the most. Patients with an AC sprain should follow a program of PRICE, or protection, rest, ice, compression, and elevation, with imaging being done to rule out damages to any of the other surrounding tissue. The GH joint allows for a wide range of motion at the shoulder. The shallow glenoid portion of the scapula provides great mobility at the expense of stability. The ligaments supporting the GH joint include the capsular or GH ligament, the coracohumeral ligament, and the inferior glenohumeral ligaments. The GH is most vulnerable when the arm is abducted and externally rotated. The joint is forced beyond its limits in this direction, the capsular ligament can fail and the humerus will dislocate from the joint. GH dislocations can cause damage to the associated structures of the joint. The fibrous cartilage labrum that sits on the glenoid of the scapula can be avulsed from the glenoid rim. If the GH joint only partially slides out of position, it is referred to as a subluxation. Sprains to the joint capsule and ligaments can result in increased laxity to the joint as a whole. As laxity or looseness increases, the demands placed on the supporting musculature to provide dynamic support increases. There is a direct relationship between laxity in the glenohumeral joint and overuse problems of the rotator cuff. The rotator cuff is responsible for providing dynamic stability to the glenohumeral joint. If the GH joint is unstable, the rotator cuff must work harder to hold the humerus in place. In this situation, the muscles of the rotator cuff are susceptible to overload and strain injuries. The nature of throwing motion requires rapid acceleration and deceleration of the upper arm. It is in this deceleration phase that the rotator cuff must contract while being lengthened, also known as an eccentric contraction. Eccentric contractions are commonly associated with muscle strain injuries and tendinitis. When rotator cuff strains occur, the athletic trainer must look at the big picture of shoulder function by exploring posture, scapular control, and overall laxity and stability. As previously mentioned, there is a direct relationship between laxity in the glenohumeral joint and overuse injuries of the rotator cuff. Another common muscle tendon injury that affects the shoulder is impingement syndrome. A syndrome is a collection of symptoms and therefore may present in different ways. The anatomy of the shoulder requires that the tendons of the rotator cuff slide beneath the acromial arch. Space beneath the acromion must be sufficient to allow for movement of the tendons of the rotator cuff, as well as the subacromial bursa and the ligaments that support the AC joint. Impingement syndrome occurs when the mechanics of the shoulder do not allow the rotator cuff to stabilize the humerus, causing the subacromial space to be compromised, leading to pain and inflammation in the rotator cuff tendon with overhead motions. While most impingement problems are chronic, an acute impingement injury can occur when the head of the humerus is jammed up against the acromial arch. This can occur with a Fuchs mechanism. Treatment of impingement syndrome includes decreasing the inflammation and pain while addressing underlying factors that promote inflammation to the structures. This most often includes biomechanical corrections and technique, improving strength and maintaining soft tissue mobility. Arthroscopic surgery may be recommended in some cases to release the coracoacromial ligament and smooth the underside of the acromion. The rotator cuff is not the only common location for tendinosis in the shoulder. The biceps tendon is also a frequent source of inflammation. The tendon of the long head of the biceps brachii helps depress and stabilize the head of the humerus during abduction. It originates from an area above the glenoid. While it is distinct from the actual GH joint, it does pass below the subacromial arch and can play a role in impingement. The signs and symptoms of the biceps tendinosis pain are similar to those associated with impingement of the subacromial structures. The chronic injury has a gradual onset and is frequently found in overhead sport athletes. Contusions are common soft tissue injuries that can occur to many areas of the body during physical activity. The shoulder frequently receives blows in many contact activities. Direct blows are the mechanism of injury for a contusion and frequently occur at the upper arm or at the deltoid or biceps tendon. They can be severe and may require support from a sling to allow for adequate rest and healing. A fall on a point of the shoulder that contuses the AC joint is referred to as a shoulder pointer. Significant contusions can cause bleeding and a pooling of blood in the muscle tissue. If left untreated, a secondary formation of calcium can take place, known as a myositis ossificans, which was previously discussed in Chapter 6. The bones that make up the elbow joint are subject to fracture. While fractures of the elbow and upper arm do occur in sports, they are most often seen in pediatric patient populations when compared to adults. Common fracture locations at the elbow include the proximal ulna, radial head, medial epicondyle, and supracondylar ridge fractures of the humerus. Common mechanisms of injury include direct blows, foosh, and fractures secondary to dislocation. In addition to fractures, overuse injuries secondary to throwing can occur to the bony structures of the elbow. While skeletally immature patients are susceptible to specific bone injuries related to throwing, mature patients are not immune from chronic bone injury at the elbow. Collateral ligaments support the elbow and protect them from excessive varus and valgus stress. Like all ligaments, they are subject to sprain injury and are graded as first through third degree. Common injury mechanisms for sprains of the elbow include foosh, combined with a varus or valgus force, hyperextension, or repetitive overloading on the medial aspect of the elbow. Sprain injuries commonly produce pain, joint laxity with activity, and/or loss of function. Rest and rehabilitation are the primary courses of treatment, but if the injury is severe enough, surgical intervention may be required. Dislocations of the elbow can occur and will result in a significant deformity. The common mechanism is again the foosh with the elbow extended, which will cause the humeral ulnar joint to dislocate posteriorly. A patient who has dislocated their elbow may have complications to neurovascular structures in the cubital tunnel, which is located in the anterolateral portion of the elbow. A patient with an elbow dislocation should be splinted, distal pulse assessed, and immediately referred for further medical attention. Medial and lateral epicondylitis are two musculotendinous injuries common to the elbow. On the medial aspect of the elbow, the prominent medial epicondyle serves as the origin for the muscles that extend the wrist. On the lateral side of the elbow, the lateral epicondyle serves as the origin for the muscles that extend the wrist. Medial epicondylitis is commonly known as golfer's elbow and is less common than lateral epicondylitis, also known as tennis elbow. Tennis elbow is caused by strong, forceful, eccentric contractions of the wrist extensor muscle group. Patients with lateral epicondylitis will have pain, may have swelling over the epicondyle, and active extension of the wrist or reproduction of an eccentric contraction will be painful. Medial epicondylitis is common to activities that require pronation of the forearm and strong flexion of the wrist. While the name implies that these injuries are straightforward inflammation or itises of muscle groups that originate at the epicondyles, literature suggests that golfer's elbow and tennis elbow are better described as tendinosis or epicondylosis that represents a condition of the tendon rather than a description of inflammation. Treatment plans for injuries to the epicondyle must decrease aggravating activities, use ice and anti-inflammatory medications for local symptoms, and promote flexibility and strength to tolerate the loads placed on the muscles. Contusions can occur at the elbow due to the prominence of the olecranon on the proximal ulna. A common acute injury associated with a contusion of the olecranon is the development of olecranon bursitis. This acute injury causes the bursa to swell and create a significant deformity to the elbow. Swelling can impair range of motion, and the size of the olecranon bursa may interfere with clothing and protective equipment. The athletic trainer must be aware that the olecranon bursa is susceptible to infection, and any patient who has sustained an injury to this region should be evaluated thoroughly and monitored for infection. The majority of nerve injuries seen in active populations can be described as neuropraxia, which is the mildest form of a nerve injury. These include injuries that do not disrupt the integrity of the nerve tissue. Friction, compression, contusion, and tension, or a combination of thereof, are the most common mechanisms. Nerve tissue can also be damaged by stretch mechanisms secondary to trauma, like fracture or dislocation. In the event of such trauma, the athletic trainer must assess the function of the associated nerves. Three of the main peripheral nerves of the upper extremity that cross the elbow joint are the ulnar, median, and radial nerves. The ulnar nerve is commonly irritated in conjunction with the injuries that are involved in the medial aspect of the elbow. Entrapment of the ulnar nerve can be found distal to the medial epicondyle where the nerve enters the forearm. The median nerve is located more toward the middle of the forearm and can sometimes be compressed under the pronator teres muscle. This injury is called pronator teres syndrome and can cause numbness, pain, and discomfort for the patient. If rest, activity modification, and symptomatic care do not alleviate the symptoms, surgical release of the entrapped nerve is sometimes indicated. Special consideration must be given to the skeletally immature patient when discussing injuries and conditions of the elbow. There are 6 ossification centers, or apotheses, around the elbow. These growth areas usually fuse or close in adolescence anywhere between 14 and 16 years of age. However, there is some variation timing of appearances of closure of these apotheses between males and females. In growing patients, these unfused or open areas are common sites of injury, particularly in athletes who take part in repetitive overhand throwing activities. Little leaguer's elbow, also known as medial epicondylar apophysitis, is a term that was popularized in the 1960s to describe the spectrum of bony changes at the elbow that are caused by medial stress and lateral compression to the elbow. The constant variables to this condition include throwing, elbow pain, and skeletally immature. Patients with this condition will present with progressively worsening medial elbow pain brought on by throwing and/or pitching. Olecranon apophysitis occurs at the insertion of the triceps tendon at the olecranon apophysis. Pain at the posterior region of the elbow is caused by rapid and repetitive acceleration and deceleration during throwing and/or pitching. The posterior elbow will be tender to the touch and the patient will present with decreased range of motion, complain of pain, and will have some presence of swelling. Radiographs are necessary to confirm this pathology, and if conservative treatment does not help, an injury may require surgery. Osteochondritis dissecans, or OCDs, is not a true inflammatory process despite its itis suffix. OCD is a focal injury to the subchondral bone and can result in degeneration of the overlying articular cartilage. In the skeletally immature thrower or pitcher, this injury is often the cause of lateral elbow pain. OCD in the elbow is caused by repetitive valgus stress overload and can be brought on together by repeatedly banging the joint surfaces of the radial head and the distal humerus together. The injury presents with the gradual onset of lateral elbow pain that is worse with activity, point tenderness over the anterior and lateral aspects of the elbow, and may affect general range of motion at the elbow. Treatment of OCD lesions in the elbow is dictated by the stability of the lesion. The stable the lesion, the less likely surgical intervention is necessary to correct the issue. The wrist and hand make up one of the most important regions in the body. The ability to reach, grasp, and use our opposable thumbs is a human trait that has allowed for great advancement as a species and certainly helps in sporting endeavors. When bone injuries occur to the upper extremity, the most common mechanisms of injury are direct blows, compression injuries, and the Fuchs mechanism, which is the most common. Fuchs is the culprit in many fractures to the forearm, wrist, and hand. The most common locations for a bony fracture are at the distal radius and ulna, the carpal bones, and the metacarpals. A fracture to the upper extremity that pushes the wrist back over the fracture, which occurs when the wrist is extended and creates a silver fork deformity, is called a Colles fracture. This fracture may involve just the radius or the ulna as well. A reverse Colles, or Smith's fracture, involves the Fuchs mechanism with the wrist inflection. The immediate care for both fractures is the same: splint, check distal circulation and sensation, and refer for radiographs. The scaphoid is a bone in the proximal row of carpal bones and articulates with the distal radius. This scaphoid is commonly injured by the Fuchs mechanism in addition to a forceful wrist extension mechanism. This is the most commonly fractured wrist bone, followed by the hamate. Pain in the anatomical snuff box, where both the extensor pollicis longus and brevis tendons border, is an indicator of injury to this bone and warrants radiographs to confirm a fracture. The hamate bone, the second most commonly fractured bone in the wrist, is typically fractured at the hook of the bone. The hamate sits on the distal row of carpal bones on the pinky side of the hand. The hammock is susceptible to fractures in sports that require a patient to hold a handle, such as tennis, baseball, and golf. The common mechanism of injury is the object being held in the hand, compressing the hook during contact of the object with something or someone else. Referral for a radiograph is necessary if the clinician suspects a fracture. Fractures can occur to other bones of the hand, more specifically the metacarpals. A boxer's fracture occurs from a direct blow with a closed fist. This fracture is most common to the fourth or fifth metacarpal. A Bennett's fracture is a fracture at the base of the first metacarpal near the carpometacarpal joint. If this fracture is present, the thumb may appear to be shorter on the opposite side. The patient will complain of pain, there will be swelling in the area, and the joint will lose function. This fracture will often require surgery to be sure the thumb function is not compromised. Fractures of the phalanges or fingers often occur as a result of a dislocation. If this occurs, it can cause issues with function of the finger if not properly treated. Immediate referral for radiographs prior to the reduction is important to be sure there are no bony fragments in the joint that can cause further issues once the joint is reduced. An extensive system of ligaments supports the carpal bones that comprise the wrist joint. The ligaments of the wrist help support the radiocarpal joint and are typically sprained as a result of a Fuchs mechanism with hyperextension. Wrist sprains produce general soreness, pain with motion, and some loss of function. Since the mechanism of injury for a sprain is the same for a dislocation and fracture, ruling out those injuries is critical. The proximal interphalangeal joint, or PIP, and distal interphalangeal joint, or DIP, are commonly sprained and dislocated in physical activity. While these joints are small and seem less important than the glenohumeral joint or the patellofemoral joint, if a sprain injury occurs, it is important for it to be looked at. In worst cases, dislocations to either of the joints can occur, and some athletes will instinctively try to reduce the joint themselves. This is not ideal, as there can be a piece of bony fragment in the joint that can cause more harm if the joint is reduced with the fragment in the joint. Splinting and referral for a radiograph is the proper course of immediate treatment. Overuse injuries to the wrist area are common in athletic activities that require repetitive motion. Both the dorsal extensor tendons and palmar flexor tendons that cross the wrist are susceptible to such overuse. Specific injuries to the tendons in the hand can lead to a group of finger pathologies that are identified by the resulting deformities that they create. A jersey finger is an injury that involves the rupture or avulsion of the flexor digitorum profundus tendon away from the distal phalanx. It is named because of its common mechanism that involves grasping of a jersey and having the flexor tendon pulled away from the distal phalanx. A patient with a jersey finger will be unable to flex at the DIP. A mallet finger can be thought of as the opposite of a jersey finger. This injury involves the tendon of the extensor digitorum at the distal phalanx to rupture, which will not allow the patient to be able to extend the DIP. A boutonniere deformity is an injury to the PIP joint where there is damage to the extensor digitorum tendon over top of the PIP joint. This occurs when hyperflexion of the PIP causes the central slip to rupture and causes the finger to be stuck in hyperextension at the metacarpal phalangeal joint and distal phalangeal joint and the PIP stuck in flexion. Splinting is the most common form of treatment for all finger tendon injuries, even those that require surgical intervention. The most common neurovascular injury to the wrist and hand is carpal tunnel syndrome. This pathology is a chronic injury that involves an irritation to the median nerve as it travels through the carpal tunnel. The median nerve crosses the wrist and sits adjacent to the deep and superficial flexor tendons that assist with movement of the wrist and fingers. Repetitive motion and holding the wrist in a flexed position for long periods of time are common causes of this condition. Treatment involves improving flexibility, decreasing inflammation, and adjusting activities. Surgery is required in some cases to decrease the pressure on the median nerve by releasing the transverse carpal ligament. Injuries to the upper extremity may only make up approximately 20% of the total injuries in the sports medicine setting, but when you consider only throwing and overhead sports, that number rises dramatically. As with the lower extremity, the athletic trainer must be able to evaluate, provide initial care, properly refer, treat, and rehabilitate a wide variety of injuries and conditions for the upper extremity. Students in an athletic training education program must work diligently to understand the relationships between anatomy and the underlying dysfunction. Those who do will be well prepared to care for a wide variety of injuries they encounter.